Today is childhood nephrotic syndrome and acute nephritic syndrome. So I'll begin with childhood nephrotic syndrome, which is one of the most common renal abnormality that we see in the pediatric age group. Now, if you look at the definitions of nephrotic syndrome, it is essentially defined as proteinuria, which is more than 40 milligram per meter square per hour or more than a gram per meter square per day, unlike the 3.5 gram per 1.73 meter square that you take in patients in adult patients, or a urinary protein creatinine ratio, which can be done on a spot urine sample and which has a value of more than 2. Now, if you look at the normal urinary protein creatinine ratios, they are less than 0.2 milligram by milligram. Whereas in patients of nephrotic syndrome, this increases to more than 2. Any value of urine protein between zero point 0.2 to 2 constitutes non-nephrotic range proteinuria. Apart from the proteinuria, because of the proteinuria, these patients land up with hypoalbuminemia. And this hypoalbuminemia results in edema and other complications, which I'll be talking to you a little later. And also there is a concomitant hypercholesterolemia, that is a cholesterol above 200 milligram per deciliter. So it's a syndrome complex which constitutes all these components. Now, there are certain definitions that we use in pediatric nephrotic syndrome, and quickly I'll go through them. Now, when we say remission of proteinuria, we mean to say that the urine has been nil or traced by dipstick, because doing timed urinary samples, then getting spot creatinine ratios, again you'll require a lab intervention, whereas on the bedside you can check proteinuria with the help of a dipstick, and that really helps you to identify any relapse or remission. So remission of proteinuria is any absence of proteinuria for 3 consecutive days, whereas the definition of relapse is that there is presence of proteinuria of +3 or more by dipstick for 3 consecutive days. Then there are certain definitions which are based on the clinical course of nephrotic syndrome in the pediatric age group. And by frequently relapsing nephrotic syndrome, we imply that the patient has had 2 or more relapses in the first 6 months of the disease, or 4 or more relapses in any 12-month period. Any patient having less than 4 relapses a year constitutes an infrequently relapsing nephrotic syndrome. Now, what is the definition of steroid-dependent nephrotic syndrome? Well, any patient who has 2 consecutive relapses during the steroid therapy or within 2 weeks of cessation of therapy constitutes a steroid-dependent nephrotic syndrome. And then comes your steroid-resistant nephrotic syndrome. Now, the earlier definition of steroid resistance was failure to achieve remission after 4 weeks of steroid therapy. But lately, last year, this definition of pediatric steroid-resistant nephrotic syndrome has undergone a change, and the new guidelines, new ISPN guidelines that were published this year, they say that you can extend this therapy for another 2 weeks. So we call it as a steroid-resistant nephrotic syndrome once the child does not respond after 6 weeks of daily prednisolone therapy in doses of 2 milligram per kg per day. I'll be talking about the specific therapy and doses in later slides. And steroid resistant patients can have an initial resistance. That means they have a non-response to initial steroid therapy. They do not respond to steroid therapy after 6 weeks of daily steroids. Whereas patients who have late resistance, they usually respond in the initial episodes, but in the later episodes, in the subsequent relapses, they become resistant to steroids. So this constitutes late resistance. Now, if you look at the therapies for initial and late resistance, while they are almost similar, but the outcome of late resistance is much better than initial resistance, and more patients of late resistance go into complete remission over the long-term course, and they have less likely chances of landing into end-stage kidney disease as compared to initial resistance. Now, if you look at the epidemiology of nephrotic syndrome in childhood, the incidence of nephrotic syndrome is about 2 to 7 per lakh child population, and the prevalence is almost 16 per lakh child population. And if you look at the data from Europe amongst the Asian cohorts there, you'll find that the incidence of nephrotic syndrome is much higher in Asian children. A recent Dutch cohort study that was published showed an incidence of about 1.5 in the European population. And if you look at the mean age of the children who presented in this study as the first episode of nephrotic syndrome, it was around 3.8 years. And more boys are affected with, even in our cohorts, we find that the ratio of children coming with nephrotic syndrome, boys are at least 2 times more as compared to girls. And if you look at the peak incidence of this condition, it is between 2 to 6 years of age. And 90% of this disease is because of minimal change disease in the pediatric age group, unlike the adult population where membranous nephropathy is the most common condition because of nephrotic syndrome. Now, if you look at the long-term course of nephrotic syndrome in childhood, if you look at the long-term course, you'll see that most of these patients will become frequently relapsing or steroid dependent. This is a large study from AIMS where over a period of 10 years, we found that almost two-thirds of the patients had become frequent relapsers or steroid dependent during their follow-up in childhood. And the proportion of infrequent relapsers was around one-third. And it's only very few patients, less than 10%, who will have only a single relapse and they will not have subsequent relapses in their course. And if you look at the proportion of patients with resistance, it is around 6 to 7%. And so the resistant form of nephrotic syndrome is less common in the pediatric age group. And if you look at this data, it is very important to understand this, because this is very important for at least the counseling of the patients. Because many times when the parents come, they feel that after the initial steroid therapy, the child will never have a relapse, and they really get disheartened when they get a quick relapse in their patient. So it is very important to emphasize to the parents that it is a disease which will have long-term consequences, and these children are prone to multiple relapses in the childhood, and therefore there is a need to follow them up and use alkylating or alternative agents besides steroids in most of these patients. Now, if you look at the etiopathogenesis of nephrotic syndrome appears to be a disease of immune dysregulation. And there is a role of both an abnormality of T lymphocyte as well as B lymphocyte. I'll be talking about these abnormalities in later slides. And there also appears to be a role of glomerular permeability factor. Permeability factor is essentially a protein which is present in the sera of many patients who have been identified with focal segmental glomerulosclerosis, and this factor appears to increase the glomerular permeability to protein. And also there appears to be a role of genetics when we talk about proteins like nephrin, podosin being defective, which are located on the either on the basement membrane or on the junctional podocytes membranes, and these also have a role. Any abnormality of these proteins also has a role in causing proteinuria. So let's first understand the T cell defects that are usually implicated in patients of minimal change disease. Now, it has been seen in relapses that there is an increased bias of cytokines towards the Th2 axis arm, or the Th2 axis is activated during the episodes of relapses, especially which are triggered by URIs and other infections. And there occurs an increased expression of IL-2 receptors and IL-2 related cytokines. And these cytokines probably cause an increased glomerular permeability and result in proteinuria. And if you look at the glomerular filtration barrier, you can see that it is primarily a three-layered structure. You have the glomerular basement membrane here, whereas this is the vascular endothelium, and this is the epithelium, which is primarily constituted by the podocytes, or which are the epithelial cells of the glomerular basement membrane. So any abnormality in any of these three layers can actually technically cause proteinuria. So a structural or a functional defect of podocytes can result in proteinuria. A thickening of glomerular basement membrane, which usually happens in conditions like membranous nephropathy or membranoproliferative glomerulonephritis or Alport's disease, which is a congenital defect of the basement membrane, can all result in proteinuria. Whereas abnormalities of endothelium we see in conditions like vasculitis, lupus and all, where the endothelium becomes more porous, and this can also technically result in proteinuria. So the etiopathogenesis of nephrotic syndrome can be multifold in different type of conditions. It would be different in MCD, different in focal segmental glomerulosclerosis, and different in conditions like membranous or membranoproliferative glomerulonephritis. Now this is again a cross section of two podocytes, and if you look at these two podocytes, you'll find that not only are there certain cytoskeleton proteins like podosin, actin, and you have the CD2 activating protein and many other, around 130 proteins constitutes the cytoskeleton of the podocytes, but not all have been implicated in the occurrence of nephrotic syndrome. And then you have some junctional proteins between the glomerular basement membrane and the podocytes. So the defect of some of these proteins has been implicated in the occurrence of certain genetic variants of nephrotic syndrome, especially the steroid resistant varieties. And if you look at the commonest of them being the Finnish variety of nephrotic syndrome, which is inherited autosomal recessively, and the gene for this is located on the chromosome 19, and this gene codes for the protein nephrin, and any abnormality of this results in the occurrence of nephrotic syndrome within the first 3 months of life. And it is important to understand the importance of these genetic variants, because if you have a genetic cause of nephrotic syndrome, then these patients are unlikely to respond to immunosuppression and you may have to stop your immunosuppression. But of all the nephrotic syndrome that we see, it's only the steroid resistant disease where we need to do the genetics, because the genetics of steroid sensitive nephrotic syndrome are less well defined. And apart from that, the Finnish variety of the nephrotic syndrome or the congenital variety of nephrotic syndrome is rather rare. And the abnormalities, most of these genetic abnormalities are usually detected in children who land up with a nephrotic syndrome before the age of 2 years. If a child has a nephrotic syndrome beyond 2 years of age, he or she is more likely to have a minimal change disease rather than any of these genetic variants. Now, a word about the role of B cells in nephrotic syndrome. Well, till late, nephrotic syndrome was considered a T cell mediated disease only. But in the last few years, there have been many studies where a drug called rituximab, which is an anti-CD20 molecule, has been used in the treatment of membranous nephropathy, then even in treatment of FSGS, MCD, etc. And this is a drug which depletes your B cell. So if a depletion of B cells also induces long-term remission, it implies that B cell also have a role in the occurrence of nephrotic syndrome, and it may be through unidentified antibody independent pathways that may control T cell proliferation. So in the body, T and B cells are not very separate entities. There is always a crosstalk which is happening between these two group of cells, and this probably results in proteinuria. So the occurrence of proteinuria is a more complex mechanism. It is not just entirely the role of T cells probably. Now, if you look at various studies, you'll find that there have been certain permeability factors which have been implicated in the occurrence of especially focal segmental glomerulosclerosis. Two studies identified a protein called angiolipoprotein, which is a glycoprotein, which is normally expressed in the podocytes at low levels. But it has been found that during relapses of minimal change disease, this protein increases up to 20 folds in urines of these patients, implying a role of angiolipoprotein also in the proteinuria. Then a soluble urokinase, a soluble plasma urokinase, has been implicated in the pathogenesis of FSGS, and it has been found that in patients of focal segmental glomerulosclerosis, when there are episodes of relapses, the serum levels and urine levels of SUPAR actually increase. And similarly, other proteins like hemopexin, CD80 levels have been found to increase in patients in relapses of minimal change disease. So it is a possibility that many of these permeability factors are responsible for the proteinuria that is happening in childhood nephrotic syndrome. So what are the clinical features and complications of childhood nephrotic syndrome? Well, the cardinal manifestation of nephrotic syndrome is edema, and many of these patients are also prone to multiple infections. I'll be talking about these individual complications in the later slides. And because of the loss of protein C, protein S, and thrombophilic factors, these patients also tend to develop multiple thrombi. although this is uncommon in pediatric nephrotic syndrome as compared to adult nephrotic syndrome, where the incidence is really high. And because of persistent hypercholesterolemia, especially in patients of steroid resistant disease, they can have prolonged dyslipidemia. And as many of these patients are treated with drugs like prednisolone, even CNI and calcineurin inhibitors like cyclosporine and tacrolimus, so they can land up with treatment related complications. I'll be talking about those complications also in later slides. So what evaluation is really needed for these patients? Well, to confirm the diagnosis of nephrotic syndrome, we need a urine protein dipstick or a timed urine sample, but generally a dipstick is good enough. Then we need to do the serum albumin and cholesterol, and we need to do the serum total proteins and the components of albumin and globulin, the serum cholesterol, which would be elevated, and the baseline urea creatinine. In childhood nephrotic syndrome, generally the urea creatinine are normal. They don't have an underlying chronic kidney disease. It's only during episode of relapses because of hypovolemia and all, you can have some mild acute kidney injury, but that also resolves with the treatment of a relapse. Before starting steroids, we need to exclude all kind of infections, especially peritonitis, pneumonias, etc. And we also need to rule out tuberculosis. Tuberculosis is rather common in our population. Therefore, a baseline chest X-ray, a good clinical examination to identify any underlying tuberculosis, and also a Mantoux test should be done in order to identify even in asymptomatic tuberculosis exposure in these patients. And a Hep B serology should be done, a surface antigen and an anti-HCV antibody to identify any underlying Hep B or Hep C mediated disease. So the investigations like the C3 complement and anti-nuclear antibody are done only if the patient has clinical features of lupus or there is significant hematuria or significant hypertension. Because most patients of nephrotic syndrome in the pediatric age group usually do not have hypertension, or they may not be having any they may not be having they do not usually have severe hypertension or hematuria or at the initial presentation of the disease. It's only once they have the disease, they, if you have features of clinical features like rash, joint pains, fever, and something to suggest of alopecia, so then in those situations you need to do anti-nuclear antibody at the onset. Now, the role of renal biopsy in childhood nephrotic syndrome is limited primarily to steroid-resistant nephrotic syndrome. You usually do not do a renal biopsy for patients of steroid-sensitive disease. So I'll be dividing the management into specific and supportive management. So first I'll talk about the specific management, which is predominantly constituted by immunosuppression. And the standard medication for treatment of childhood nephrotic syndrome is prednisolone. And it has been used since the 1950s, and it is the cornerstone for management of steroid sensitive disease. Now, according to the new guidelines as well as the old guidelines, the first episode of nephrotic syndrome needs to be treated with prednisolone either in doses of 60 milligram per meter square per day, or you can even use a weight-based criteria, that is 2 milligram per kg per day, which is much easier to use in a clinical setting or in a bedside setting, and it can be given as a single or as a divided doses for a period of 6 weeks. And after 6 weeks, we can give doses as 1.5 milligram per kg or 40 milligram per meter square per day as single morning alternate day doses. Whenever you give doses in an alternate day manner, they should be given as single morning doses, and no tapering is required for stopping these doses. So at the end of 6 weeks of alternate day therapy, you can abruptly stop steroids in childhood nephrotic syndrome because you have been already giving the drug as alternate day at the end of 6 weeks. Then what is the treatment for each relapse? For each relapse, you need to give prednisolone in doses of 2 milligram per kg per day until the urine protein becomes nil or trace for 3 consecutive days. That is, we achieve remission. And subsequently, the steroids can be reduced to 1.5 milligram per kg on alternate days for 4 weeks. So the standard therapy for first episode is 12 weeks of steroids, whereas the standard therapy for treatment of each relapse is 6 weeks, around 6 weeks. Now, what happens to the patients who become frequently relapsing or steroid dependent? Well, if it's an infrequently relapsing nephrotic syndrome, that is less than 4 relapses a year, you need to treat each relapse with 6 weeks of steroids. But if your relapses are more than 4 a year, or the patient becomes steroid dependent, that is the moment you start tapering the steroids, the child relapses again. So what are the strategies to encounter this kind of disease? Well, the various strategies are to maintain these patients on long-term alternate day prednisolone. And when we say long-term alternate day prednisolone, it is doses as small as 0.25 to zero point 0.5 milligram per kg on alternate day. And we can safely give these doses without causing complications like growth failure or hypertension or diabetes for a period of about 9 to 18 months. But generally beyond 1.5 years, we do not like to continue with alternate day steroids. In case a child requires alternate day steroids beyond 1.5 years also, in those situations, we would like to give certain alternative agents. Now, if the requirement of the dose is more than 0.75 milligram per kg per day, that means that these children require some form of alternative agents. So this is the management protocol. Okay, I'll just first go to the alkylating agents first. Now, in case the child does not respond to low dose alternative steroids, then what are the options for treating frequently relapsing and steroid dependent patients? Well, the first alternative is cyclophosphamide. But cyclophosphamide usually works only in children beyond the age of 6 years. So less than 6 years, you will have to continue with alternate day steroids probably. And in children beyond 6 years of age, you can use cyclophosphamide. It suppresses both T and B cell function by almost 30 to 40%. And the doses of oral cyclophosphamide are around 2 to 2.5 milligram per kg per day. And we give it for a period of 12 weeks. And generally, we do not give a second course of oral cyclophosphamide, even if it doesn't work, because you know that there are gonadotoxic upper limits of cyclophosphamide of 200 milligram per kg for males and 250 milligram per kg for females. So if you give a second course, you will reach to these gonadotoxic doses. Therefore, only a single course of cyclophosphamide is given during the therapy. And if you look at the side effects of oral cyclophosphamide, they are primarily hair loss. You can have leukopenia in about 1/3 of these patients. May increase the predisposition to infection, but it is only a small number. And hemorrhagic cystitis is usually not reported with oral cyclophosphamide. It is primarily a problem when you give intravenous cyclophosphamide. And alkylating agents can maintain remission for prolonged periods of 2 to 5 years. So for the first 2 years, it is less likely that most of these patients will again have a relapse. But beyond 2 years, yes, they again start relapsing. And then you'll have to treat each of these relapses with standard therapy of steroids. Now, one thing, when you're giving oral cyclophosphamide, it needs to be given with alternate day steroids. Cyclophosphamide alone does not work. You need to combine it with alternate day steroids, and this is for a period of 3 months. And every month you need to monitor these patients for infections, and you also need to do a total leukocyte counts. If at any time your total leukocyte counts are less than 4,000, you'll have to stop the therapy for a while, and maybe you can resume it after 1 to 2 weeks once the TLCs recover. The nadir of once you start oral cyclophosphamide, the nadir of the counts comes at around 3 to 4 weeks. So it's only after the first 3 weeks of use that you'll find that there is a fall in the counts. And these are again, as I said, the response rates for frequently relapsing nephrotic syndrome, and they are around 72% for at 2 years. But however, after 2 years, the effect of cyclophosphamide actually declines, and these children again start relapsing beyond 2 years of age, and again then they would require steroids for the treatment of relapses. Now, another alkylating agent which has been primarily used in the past, and we also use it very infrequently. I remember using it only in 3 to 4 patients in my whole 20 years of pediatric nephrology practice. So it is used less frequently, but you should know that the other drug is chlorambucil, and it is not usually used as a first-line cytotoxic agent because it's more toxic. The infection rates with chlorambucil are much higher, and it also tends to have neurotoxicity. It can precipitate seizures. So while it is available in the market, but we use it only in situations where we require a second course of cyclophosphamide, and it was primarily used in an era where calcineurin inhibitors like cyclosporine and tacrolimus were not available. In the present era, when you have much safer drugs in the form of calcineurin inhibitors, you would not like to use chlorambucil. Now, another drug which has been used and which is very effective also in children below the age of 6 years is Levamisol. Well, Levamisol is actually primarily an anti-helminthic agent, and it has been used in various immunomodulatory diseases since the 1980s. So this drug has an immunomodulatory effect. And what is this immunomodulatory effect? Well, it tends to suppress your Th2 axis. As I talked earlier, in episodes of relapses, you find that there is an activation of Th2 pathway. And this is a drug which is inhibiting the Th2 pathway and upregulates the Th1 arm. And possibly this is the reason that it maintains long-term remission in patients of frequently relapsing nephrotic syndrome and steroid-dependent nephrotic syndrome. And it is an excellent steroid-sparing agent. And it works very well, especially in Indian population. And we use it in doses of 2 to 2.5 milligram per kg per day. And as the drug has a long half-life, it is usually given in alternate day manner. Daily therapy should be avoided, and the maximum upper limit is 150 milligram. And we get these tablets are available commercially as 50 mg and 150 mg tablet. And while it is a very safe drug, but rarely neutropenia, rashes, and cutaneous vasculitis has been reported. So we do also monitor counts for patients on levamisol, but it is not as frequently as every month. In this case, we monitor them every 3 months. Now, a word about a newer agent, which is mycophenolate morphetin. This is a drug which inhibits both T and B cell proliferation, and it is used in doses of 25 to 30 milligram per kg per day in pediatric age group. And it is given because it has a half-life of about 10 to 12 hours. So it is given as BD dosing. And it is available as 250 and 500 mg tablets. And lately, last year, a syrup of Mycept has also been launched. So it can be used even in patients who are younger than 2 years, because taking large tablets is difficult for children below the age of 2 years. So mycophenolate morphetin has emerged to be a good drug for patients of frequently relapsing and steroid dependent nephrotic syndrome patients, especially those where you can't give cyclophosphamide, that is, they are less than 6 years of age. But some common complications of this drug are gastritis, diarrhea, leukopenia. But though gastritis is more common, leukopenia is rather infrequent in occurrence. And the usual duration of treatment with mycophenolate morphetin is around 12 to 24 months. And it acts as a good steroid sparing agent, especially in patients with frequently relapsing and steroid dependent disease. Now, the new drugs in the arsenal of nephrotic syndrome, which since the 1980s has been cyclosporine and tacrolimus. While these drugs were used primarily for post-transplant patient in 1980s, since the year 2000, the trials have been using these drugs in patients of nephrotic syndrome also. Now, calcineurin inhibitors are essentially drugs which we reserve only for hardcore steroid resistant disease. We usually don't use these agents because they are also nephrotoxic agents, and there are various other complications of these drugs also. So they are used only in steroid resistant disease where they are first line of therapy, whereas for steroid sensitive disease they are used only if there is a failure to treatment with steroids, with cyclophosphamide, with MMF, and in those situations you can use calcineurin inhibitors. Now, if you look at the mechanism of action of calcineurin inhibitor, this is a cross section of a lymphocyte. And if you see both cyclosporine and Techrolimus, which was earlier called in the experimental form as the FK binding protein. FK506 was the experimental name to Techrolimus, and later it was named as Techrolimus. And both these drugs bind to their receptors in the protoplasm of the cytoplasm of the T lymphocyte. This is the cyclophilin, the cyclosporin binding protein, and this is the TAC binding protein. And both these drugs inhibit the calcineurin protein, which in turn inhibits the dephosphorylation and leads to a reduced secretion of interleukin 2 gene, and subsequently all IL-2 based cytokines will be reduced. And this also affects it essentially inhibits the interleukin 2 driven T cell activation. So while the pathways are both, they act at the common, both act at the common pathway, but their receptors within the cytoplasm are different and their toxicities are different and their potencies are also different. In fact, tacrolimus is almost 40 times more potent as compared to cyclosporine. And if you look at the dosing of cyclosporine, it is given in doses of 4 to 6 milligram per kg per day, and it is given in two divided doses. You can use a surface area based calculation also, and in nephrotic syndrome, you can give 100 to 150 milligram per meter square per day if you want to use this dosing pattern. But in pediatric age group, always the dosing pattern of milligram per kg per day is much easier to use. It's available as capsules of 25, 50 and 100 mg capsules, and a syrup of cyclosporine is also available. So this is a major advantage that you can again use it in younger patients where they will not be able to take capsules, and the general treatment requirement is around 1 to 2 years. And most patients, when you start them on cyclosporine, especially the steroid resistant disease, you will find that the effect comes only after the first 2 months. So the median time to response, if you look at in most studies, is around 10 to 12 weeks. So we do not expect an immediate response, and this we need to communicate to the parents as well. So why are we very judicious in the use of cyclosporine? Why don't we use it for all patients? Well, the primary reason is that it can cause nephrotoxicity, and this nephrotoxicity is primarily in the form of interstitial tissue damage. So interstitial damage of the interstitium of the kidney, and so you use it only in patients where they have a steroid resistant disease, they have not responded to any other therapy, then you can use this drug. And this incidence of nephrotoxicity usually happens with prolonged use of more than 2 to 3 years. So that is why you try to keep the duration of therapy for not more than 2 years. And with cyclosporine, you also find a lot of cosmetic side effects like gingival hyperplasia of the gums, hypertrichosis, hypertension, etc. And therefore, while you can do cyclosporine drug levels and you want to maintain the drug levels between 100 to 150 nanogram per ml to prevent any prolonged nephrotoxicity, but this cannot judge the nephrotoxicity. For judging the nephrotoxicity, you have to do an invasive investigation like renal biopsy, and this is usually planned beyond 2 years of therapy of cyclosporine. So this becomes, cyclosporine therapy becomes one of the indications of doing renal biopsy in pediatric age group. Now, the other calcineurin inhibitor is your tacrolimus. And the mechanism of action, as I said, is similar to cyclosporine, but the side effects are different. It can cause whitery diarrhea in almost one-third of the patients. Nephrotoxicity, well, it's said to be a little less than that of cyclosporine, but it tends to also precipitate hyperglycemia. And we've seen patients landing up with type 2 diabetes in patients of who have been treated with tacrolimus. So it has to be used cautiously, and a baseline HB1AC should always be done before starting therapy with tacrolimus. And the usual doses of tacrolimus is 0.1 to 0.15 milligram per kg, and it is also given in a BD manner, and it can be given daily for a period of 12 months. We try to avoid therapy with tacrolimus beyond 2 years. And it has the major advantage of tacrolimus is that it has no cosmetic side effects. So especially in adolescent children, if you are starting therapy for steroid resistant disease, especially so the adolescent children, this tacrolimus would be superior to use of cyclosporine. Now, this is just a diagram which is showing the various areas at which most of these drugs are acting. Now, if you talk about prednisolone is a pan-immunosuppressant. It acts at all growth cycle effects. At all the cycles of T lymphocyte growth. Whereas in drugs like cyclosporine, you can see it affects primarily the release of IL-2 by the T lymphocyte. A drug like Levamisol is basically upregulating the Th1 cycle and dysregulating the Th2 cycle. Whereas a drug like rituximab is affecting the plasma cells and it reduces the production of B lymphocytes, and it reduces the production of certain antibodies as well as inhibits T cell cycle. So eventually the products of all these cycles are eventually affecting basically your podocytes. Now, if you look at a normal kidney, the podocytes would be normal, whereas in a child of minimal change disease, we know that there occurs an effacement of podocytes. So the byproducts of some of these cytokines are causing a proteinuria at the level of podocytes. So this is how, most of these drugs are acting in preventing the proteinuria of nephrotic syndrome. So coming to the clinical indications of doing renal biopsies in these patients, well, if there is an early onset and maybe if we are suspecting a genetic cause of nephrotic syndrome, then we should be biopsying them. If there is gross or persistent hematuria, then this looks more like a nephrotic syndrome and less likely to be minimal change disease. So these patients would require a biopsy. A low serum C3 levels may occur in patients of lupus and even in Hep B, Hep C mediated membranous nephropathy. So they would require a biopsy. And if there is sustained hypertension, then this also looks like a not like a minimal change disease. So these patients would also require a biopsy. And if there is a rapidly progressive renal failure kind of a condition that the child is having a severe AKI, so even in this situation, the child will require a biopsy to rule out a crescentic glomerulonephritis. And when you are suspecting secondary causes of nephrotic syndrome, that is the patient is Hep B positive, Hep C positive, or ANA positive, or HIV positive. So in these situations, you would like to do a biopsy to see whether it is a viral mediated nephrotic syndrome. Well, most patients do not require of steroid sensitive therapy do not require biopsy, but if they have a steroid resistant disease, that is at the end of 6 weeks, if you still find that they are having proteinuria despite 6 weeks of daily therapy, then these are the patients who would require biopsy. And if you are planning to start cyclosporine or tacrolimus, even in steroid sensitive patients, you would need to do a biopsy to rule out any pre-existing tubulointerstitial damage. Now, what to look for in the biopsy? Well, minimal change disease on a light microscopy, which is this light microscopy picture is stained with an H&D stain. It shows essentially normal glomeruli. On light microscopy, you would not find any changes in the glomeruli, and the tubular interstitium would also be normal. But if you do an electron microscopy for the same patient, you'll find that while the basement membrane and other structure of the glomeruli are normal, but there is effacement of the podocytes. These podocytes can be very well identified on an electron microscope. So if at all you want to identify minimal change disease, you won't be able to identify it on light microscopy. You'll require an electron microscope to identify the condition. Now, if you look at the light microscopy findings of a condition like focal segmental glomerulosclerosis, this is a high power, this is a single glomeruli under high power. And in this HNE stain, you can see that this area is more darkly stained. So this is an area of sclerosis where only a particular segment of the glomeruli is sclerosed. So why do we call it as focal segmental glomerulosclerosis? Well, only a few glomeruli are involved, and out of that glomeruli also, only a portion of that glomeruli is involved. Therefore, it is called focal and segmental glomerulonephritis. This is another FSGS biopsy cross section, and this is under silver stain, which stains for the sclerotic regions very well. And you can see that this is the sclerotic area within this glomeruli. These are the H&D staining, and this is the past staining where you can again see the sclerotic area in a very well manner. So for a good renal biopsy, you need to have minimum of 10 to 20 glomeruli to make a definite opinion whether it is minimal change disease, focal segmental glomeruloscleritis, or it is a a membranous nephropathy or a membranoproliferative glomerulonephritis. So this is a biopsy picture of a membranous nephropathy where the changes are there across the entire region of the glomeruli. You can see that there are basement membrane deposits across the entire glomeruli, and this is a membranous GN. And if you look at, this is how a immunofluorescence picture, because when we send biopsy for 3 specimens. This is your light microscopy, this is for your immunofluorescence, and this is for your electron microscopy. And in the immunofluorescence pattern, you run the immunofluorescence for various antigens like complements, IgG, IgM, etc., etc. And in patients with immune-mediated diseases like membranous and membranoproliferative glomerulonephritis, you find plenty of immune deposits within the kidney. Whereas in patients of minimal change disease, you don't find any immune deposits. So whatever is happening in the plasma, but it is not happening at the level of glomerulus. At the level of glomeruli, you only have effacement of podocytes and minimal change disease. Similarly, in this electron micrograph, you can see that the basement membrane is showing lot of hump-like deposits, and this basement membrane is actually thickened. So electron microscopy is a very good investigation to identify abnormalities not only of podocytes but also of the basement membrane, and you can even identify whether the deposits are on the subendothelial side of the membrane or subepithelial side. So this is the subendothelial side. So generally you find deposits on the subendothelial sides in conditions like membranoproliferative disease, whereas these are subepithelial deposits or hump-like spikes which we usually see in patients of membranous nephropathy. So in these conditions, an electron microscopy becomes an important tool to identify these secondary causes of nephrotic syndrome. Okay, so let's come to some of the clinical manifestations and of nephrotic syndrome, and to the role of supportive therapy in management of this child. Now, edema, as I said, is the cardinal feature of nephrotic syndrome, and it primarily occurs because of the hypoproteinemia. Now, there are two hypotheses which have been identified for the causation of edema in children with nephrotic syndrome. And the first hypothesis is your underfill hypothesis, which implies that because of the protein loss in urine and hypoalbuminemia, there occurs a vascular underfill, that is, there is vascular hypovolemia, and this increase, and there occurs edema because of the interstitial diffusion of the tissue fluid. Whereas in conditions like FSGS, membranous nephropathy, secondary nephrotic syndrome, there are primary intrarenal changes which cause a salt and fluid retention, which causes an increased intravascular volume, and which is your basic basis for your overfill hypothesis. It is very important to differentiate between, underfill and overfill mechanisms, because we tend to use diuretics in all patients who are edematous. But if they are in a situation of vascular underfill, then use of diuretics can be very detrimental. So it is important to differentiate whether the patient is having hypovolemia or hypervolemia. So clinically, while biochemically you can do a fractional excretion of sodium, in an underfill situation the fractional excretion of sodium would be rather reduced, because most of the sodium would be reabsorbed in the tubules, whereas it will be high in patients of overfill hypothesis. But most of the time we identify vascular underfill and overfill using our clinical parameters. Patients who have a vascular underfill will have peripheries which are cool. There could be tachycardia clinically. The blood pressures may be on the lower side. So if you pump in diuretics in such a situation, it will lead to shock in these patients. So these are the patients where if you give them albumin, it will be much more useful to treat their edema. Whereas in these patients who have primarily an overfill type of situation, which usually happens in patients of steroid resistant nephrotic syndrome, you will have hypertension, peripheries will be warm, there will be no tachycardia, and they will be grossly edematous. So it will be the best treatment for this group of patients would be to use diuretics, especially furosemide first. If you give albumin in these patients, they will actually go into a situation of vascular overload, pulmonary edema, and may even throw up seizures. So you have to be very cautious in your use of diuretics or albumin, and you need to decide which patients will require albumin and which patients will require diuretics first. So this is how most patients present to us when they get hospitalized. Edema of nephrotic syndrome usually begins from the face, and it may cause ascites, it may cause pedal edema, it may cause pedal edema, ascites, and it can even cause pleural effusions and the face. And sometimes we find that the eyes are almost closed because of severe edema. And this child has presented with scrotal edema. Presence of scrotal edema is an indication to immediately admit and consider this child for either diuretics or albumin, depending upon his volume status. As I said, just figure is showing you the underfill hypothesis, that if you have proteinuria, you have reduced serum albumin, and there is a decreased oncotic pressure, which results in shift of intravascular and interstitial fluid and results in edema. And this reduced hypovolemia in the vascular compartment leads to an increase in renin-angiotensin-aldosterone mechanisms, which actually cause a decrease in GFR, and they also cause an increased tubular sodium reabsorption, and therefore this leads to a reduced fractional excretion of sodium in urine. Whereas opposite mechanisms are happening in patients who have a vascular overfill. Here, because of the renal disease per se, there is a fall in GFR, and because of this primary reduction in GFR, there is a reduced renin-angiotensin-aldosterone production, and this in turn leads to an increased plasma volume and blood volume, and therefore in this type of a situation the use of albumin may not be very useful. If you use diuretics in this situation, it will work much better. So when you manage edema, it is very important to assess the volume status. And if you have to give albumin, you can use 20% albumin, which is available in most of our wards. But if you are using albumin as a volume expander, especially in a child who has nephrotic syndrome and shock, you can use 5% albumin. And if you have to use diuretics in patients who have vascular overfill or normovolemia for treatment of edema, you can use furosemide in doses of 2 to 8 milligram per kg per day. Generally, in hospitalized patients, we do not start with oral drugs. Oral drugs are used only on an OPD basis for a period of 48 to 72 hours. And if the patient doesn't respond to oral therapy, then you can go on to injectable therapy. And if the patient does not respond to injectable furosemide also, you can add other diuretic agents like metolazone and hydrochlorothiazide, which are thiazide group of diuretics. And if the patient does not respond to this also, then in those situations you can consider giving furosemide infusion, which can be given for a period of 24 to 48 hours. But mind you, when you are using high doses of these diuretics, it is very important to monitor the sodium and potassium, because these patients can develop hyponatremia and hypokalemia, and hypokalemia is a very common complication of these patients. So therefore you can add a drug like aldactone or spironolactone in doses of 2 to 3 milligram per kg per day for their potassium sparing action. Now, word about immunization in these patients. No, I think I missed okay. Before going on to the immunization, I think I have missed something in the infection. A very important part before immunization, you must understand that many of these patients are prone to repeated infections. The reason for these infections is basically the loss of complements, properdins, and immunoglobulins, which are also proteins. And because of the concomitant proteinuria, most of these proteins are lost, which predisposes these patients to infections. And apart from that, there is huge edema as well. And this edema too predisposes to edema fluid is a good nidus for infections. And apart from that, in many of these patients, we have been using steroids and other immunosuppressants. So during relapses, they are more prone to infections. And the common infections in these patients that you encounter are your pneumonias, you have skin infections, and you have pyodermas, you can have cellulitis, and you can have pneumonias and pneumococcal, and primarily you have a increased predisposition to capsulated organisms, that is H influenzae and pneumococcal infections are more, both of them being gram positive agents, are more prone in these patients. So, and these patients can present with spontaneous bacterial peritonitis also. So any patient of nephrotic syndrome, if he has come to you with ascites and presents with pain abdomen and has diarrhea, or if there is abdominal tenderness, then this child is probably having peritonitis. So such a patient will require a peritoneal tap. You'll require blood investigations like TLCs, and you may require a chest X-ray to identify a pneumonia. And once you confirm the diagnosis of infection, most of these patients would require antibiotics. And the antibiotics to choose in these patients would be drugs like third generation cephalosporin, that is your ceftriaxone. The reason being that it covers both your pneumococcus as well as H influenzae. Drugs like aminoglycosides should be used only as second line in these patients, because they are at a higher predisposition to develop AKI, and sometimes there is a concomitant AKI, so we avoid the use of aminoglycoside, and a single antibiotic like ceftriaxone may be given for a period of 7 to 14 days in these patients for treatment of pneumonias and peritonitis. So for prevention of these infections, it is very important that all these patients should have undergone their primary immunization. And when you give the vaccines to these patients, the live vaccines should not be given when the child is on steroids or other immunosuppressive agents. But if the steroids cannot be stopped, like in patients of steroid resistant disease or frequently relapsing disease, then you can immunize these patients once they are on a daily steroid of less than 0.5 milligram per kg per day. And we did this study at our institute only, and we have seen that at least for hepatitis B, we found that the protection levels, even in children who were immunized for hepatitis B, was much lower in patients with steroid resistant disease as compared to steroid sensitive nephrotic syndrome, because these patients, they keep having multiple episodes of proteinuria and they get more intense immunosuppression as compared to steroid sensitive disease. And similarly, in another study this year that we published, we found that even the titers for DPT and measles are lower in patients with steroid resistant disease as compared to steroid sensitive nephrotic syndrome. So these patients would require multiple boosters apart from the extra boosters for even for DPT and measles, not just for hepatitis B. And the extra vaccines that need to be given to these patients to prevent infections are your 23-valent pneumococcal vaccine, which is a polysaccharide vaccine, and a meningococcal AC, the quadrivalent meningococcal vaccine, or a conjugate which is also a polysaccharide vaccine, can be given to these patients. And varicella vaccine should also be given to these patients, because all these infections can cause real problems in children with nephrotic syndrome and can also predispose to relapses. So these extra vaccines should be given to all patients of nephrotic syndrome. Now, the other complication of these patients is thrombosis. If you compare the thrombosis incidence to adults, it is much lower in pediatric nephrotic syndrome, and it primarily occurs due to the losses of protein C, protein S, and antithrombin 3. And if you look at, most of these patients have venous thrombosis, the incidence of arterial thrombosis is much lower. And the commonest thrombosis that we see usually in our clinical practice is deep vein thrombosis involving the lower limbs. We can have axillary vein thrombosis, then we can have cavernous sinus thrombosis, etc. Apart from these loss of protein C, protein S, and antithrombin 3, other factors like intensive use of diuretics, which can cause hypovolemia, presence of infection, dehydration, trauma due to multiple cannulations, venipuncture, and immobilization also are factors which can predispose to thrombosis in these children. So if you look at it in this diagram, there are other factors also apart from the loss of these protein C, protein S, and antithrombin 3. In fact, in about 5% of nephrotic syndrome patients, in some studies, they have identified thrombophilic mutations also and prothrombotic factors also, which predispose to some of these patients too, because all the patients do not develop thrombosis. It's only a subgroup of the patients who are actually developing thrombosis. So other factors may also be contributory. So how to manage these patients with thrombosis? Well, most of them first you need to confirm thrombosis, and this can be done by doing an ultrasound Doppler of the lower limbs and the area where you are suspecting the thrombosis, and MRI or a CT angio may be required for identification of either the cavernous sinus thrombosis or the pulmonary thrombosis, which can occur in these patients. And D-dimer levels, which can be done very easily in the lab, will also be elevated in patients who have thrombosis. And the treatment is usually we use low molecular weight in a heparin like enoxaparin for a period of about 1 to 2 weeks, and then we overlap that with oral warfarin, and oral warfarin is given for a period of 3 to 6 months, or in patients of steroid sensitive nephrotic syndrome, and children of steroid resistant nephrotic syndrome will require till the relapse persists. Once the patient goes into the remission, then you can stop the therapy because the predisposition to thrombosis now declines. Hypertension in these patients, well, the incidence of hypertension is around 12 to 15%, and it usually happens in patients of focal segmental glomerulosclerosis. And the aim of maintaining the BPs is to maintain the blood pressure below the 90th centile for the age, gender, and height for these patients. And the best antihypertensive for this group of patients is use of ACE or ARBs, but a combination of the ACE and ARBs should be avoided because it can precipitate hyperkalemia. But if you are not able to control your blood pressures with ACE and ARBs, you can use diuretics, especially in patients who have a steroid resistant disease. And then you can use drugs like calcium channel blockers like amlodipine and beta blockers like atenolol and metoprolol if you are not able to achieve the target BPs with these drugs. Now, prolonged use of steroids can cause marked osteopenia in these patients and even predispose to vitamin D deficiency. So all these patients require calcium and vitamin D supplementation with steroids. Now, a word about dyslipidemia of nephrotic syndrome. Well, the dyslipidemia occurs only when there is proteinuria. So once you control proteinuria with the use of drugs, then this dyslipidemia would disappear. So the use of statins is recommended only in persistent proteinuria, that too in patients with steroid resistant nephrotic syndrome, because the best strategy to manage dyslipidemia of nephrotic syndrome is to take care of the proteinuria by using steroids or alternative agents. And the moment proteinuria disappears, the dyslipidemia is also going to disappear. Use of statins we effectively use only in patients of steroid resistant disease who do not go into remission. So what diet we should be recommended to these patients? Well, if they have protein losses, they should receive diet which is high in protein. This is unlike adult nephrotic syndrome where you actually recommend protein restriction to prevent progression of the disease. But in the pediatric age group, the persistent loss of protein can predispose to malnutrition and cause growth failure. Therefore, these patients require higher amounts of proteins, especially when they are having proteinuria. But fats should be restricted to less than 30% of the calories, and saturated fats should be avoided. And salt restriction is recommended only for patients who have persistent edema and or they have hypertension. Otherwise, in regular nephrotic syndrome, you don't need to restrict salt. Only extra salt can be avoided. And steroids often cause hyperphagia. So when the patients are receiving daily steroids for a period of 6 weeks, especially during first episode, it is important to emphasize a balanced diet intake for these patients, and especially an intake of fruits and vegetables will help in reducing the hyperphagia. A word about the use of stress doses of steroids. Well, stress doses of steroids in doses of 50 to 75 milligram per meter square of hydrocortisone or oral prednisolone is recommended in patients who have been on steroids in the past in the last 1 year. And this dosing is to be supplemented for all patients who land up with serious bacterial infections or are going up for any kind of surgery. And if you need to give these steroids, they need to be given for all patients who have received more than 2 weeks of daily steroid therapy in the last 1 year. So often these patients would require steroid doses, stress doses of steroids as well. Well, before this is the okay, let's shift to acute nephrotic syndrome rather than talking about the nephrotic syndrome alone. So now, compared to nephrotic syndrome, acute nephrotic syndrome occurs less frequently in the pediatric age group, and it is a symptom complex which is characterized by an abrupt onset of gross or microscopic hematuria with varying degree of proteinuria. And if you do a urinalysis, there would be casts and there would be RBCs in the urine, and most patients land up with fluid overload and hypertension, and they have a variable degree of insufficiency. So it's a syndrome complex which is accompanied with hematuria, proteinuria, signs of hypertension, and signs of renal insufficiency. And if you do a biopsy in these patients, most of the time there will be acute proliferative changes in the glomeruli. So what are the causes of acute nephritic syndrome in the pediatric age group? One is the acute glomerulonephritis, or secondly, it could be an acute presentation of a chronic glomerulonephritis like hepatitis or hepatitis C mediated disease, lupus nephritis, or things like IgA nephropathy, etc. So if you look at the acute GN, the acute glomerulonephritis contributes to roughly 10 to 20% of all referrals to the pediatric nephrology units, and it is a cause for 20 to 30% of admissions of renal patients in the pediatric nephrology unit. And if you look at the etiology of this acute glomerulonephritis, in almost 85 to 90% of the time, it is post-streptococcal. Amongst the non-post-streptococcal infections, bacterial infections like infective endocarditis, VP shunt nephritis, sepsis, typhoid, infection with multi-resistant staph aureus or methicillin-resistant staph aureus, viral infections like Hep B, Hep C, IM, even echo, varicella, mumps, measles, all these can cause a post-infectious GN. And parasitic infections like malaria and toxoplasmosis rarely have also been implicated in the causation of acute glomerular nephritis. And amongst the non-infectious causes, you have primary glomerular diseases like MPGN, MGN, IgA nephropathy, or multiple systemic diseases like SLE, HSP, vasculitis. So all these diseases do not present like nephrotic syndrome. All these causes usually present like a acute nephritic syndrome where there is always hematuria in these patients. So a word about post-streptococcal GN. 95% cases of acute nephritic syndrome are due to PIGN, and usually it develops after 1 to 2 weeks after pharyngitis or 2 to 6 weeks after a skin infection due to a nephrogenic strain of group A hemolytic streptococcus. And the clinically apparent GN, however, develops only in 2% patients. So why only in these 2% patients? Possibly there is a genetic predisposition, and there may be a role of the HLA predisposition in the occurrence of renal involvement after post-streptococcal disease in some of these patients. And the most frequent age groups is 2 to 12 years. And again, it is more common in males as compared to females. So if you look at the clinical manifestations of post-streptococcal GN, well, hematuria. Without hematuria, you cannot call it as acute post-streptococcal glomerulonephritis. Hematuria occurs in almost 100% of these patients, followed by proteinuria, edema, hypertension. And if you look at the incidence of nephrotic range proteinuria, it is less than 5%. So most of these patients will have a non-nephrotic range proteinuria. And if you look at the incidence of azotemia, that is renal dysfunction, it occurs in 25 to 40% of the patients. And mortality, however, is very low. So what are the mechanisms of renal injury in patients of post-streptococcal glomerulonephritis? Well, it appears that the trapping of immune complexes in glomeruli can result in a lot of inflammation in these glomeruli. And there also appears to be a molecular mimicry between streptococcal and renal antigen, which leads to inflammation in the kidney, which attracts a lot of these antigens to the renal basement membrane. And there also occurs a direct complement activation by streptococcal antigens, which are planted in the glomeruli. And this actually results in removing all the complement from the blood into the kidney. And that is the reason why you find that the complement levels of C3 and C4 are actually reduced in patients of acute glomerulonephritis. And looking at the biopsy features of these patients, it seems that intraglomerular deposition of fibrin and fibrinogen also has a role in causation of the disease. So some of the streptococcal serotypes which are implicated in the occurrence of glomerulonephritis based on the type of M proteins, well, these are different for pharyngitis as well as pyoderma, but we find glomerulonephritis more common after pyoderma, unlike acute rheumatic fever, which usually occurs after pharyngitis. So it is something like your acute rheumatic fever. Here the target is the kidney rather than the heart valves. So what diagnostic evaluation needs to be done for these patients? Well, we need to do a good urine analysis. We need to look at the protein. We need to look at the microscopy to identify the RBCs, the presence of any dysmorphic RBCs, because RBCs which come from the glomeruli, they tend to get altered once they pass through the tubules. So you may find a significant proportion of these patients having dysmorphic RBCs, and there could be a lot of WBC and RBC casts as well. And many of these patients will have mild to moderate renal dysfunction. And you can do an ASLO antibody. Anti-ASLO is positive in almost 85 to 90% of these patients. The other antibodies like anti-hyaluronidase, anti-DNase B are less easily available to us. So we rely mostly on presence of an elevated anti-ASLO levels in these patients, and complement levels are also, especially C3, is reduced in more than 95% of these patients. And renal biopsy is usually indicated in patients only when there is moderate to severe degree of renal dysfunction. That is, the patient has presented to us like a rapidly progressive glomerulonephritis. So the indications of renal biopsy are usually, most of these patients self-resolve of the hematuria and proteinuria beyond 4 weeks. So if you have persistent macroscopic hematuria beyond 4 weeks or proteinuria beyond 4 weeks, this is, we are talking about macroscopic hematuria. Microscopic hematuria can persist for even up to 1 year in patients of acute GL. So if these are there, you need to do a renal biopsy, because this looks like a presentation of a chronic glomerulonephritis. If the hypocomplementing anemia presentation persists beyond 12 weeks, most couples come back to normal within 10 to 12 weeks after episode of PSGN. So if this is persisting, then this could be something else like MGN, MPGN, or like lupus. And if there is absence of hypocomplement anemia, so all patients of PSGN will have reduced complement levels. If at the initial presentation complement levels are normal, this could be something else like IgA nephropathy, etc. So these patients would also require a biopsy. And as I told you, rapidly progressive renal failure in patients where you may find presenting glomerulonephritis on biopsy. So these are the patients who will require very intense immunosuppression. So therefore, they need to be biopsied, or if the patient has atypical presentation. Now, in biopsy, what are you likely to find? Well, there occurs lot of hyperproliferation in these patients. You can see this glomeruli appears to be large, and there is lot of blue dots. This is lot of neutrophilic infiltration, which happens in patients with acute glomerulonephritis because it's an inflammatory process. And you can see lot of complement deposition on this IF immunofluorescence pattern, and this helps in identifying these patients of PSGN. But mind you, this is not done for all patients. This biopsy would be done for less than 5% of these patients who have not recovered. So what is the treatment? Well, this biopsy would be done for less than 5% of these patients who have not recovered. So what is the treatment? You just need to do symptomatic treatment, as most hematuria will resolve on its own. So there is no need to worry for the hematuria. As most patients will present to you with hypertension, you need to restrict their fluid and salt if they have hypertension, which is much severe. But most of these patients will require some diuretics, and for the blood pressure control will require amlodipine. And the usual duration for which these diuretics and therapy is required is around 10 to 14 days. Most patients start recovering beyond 2 weeks. So the drug doses usually required to be used for not more than 2 weeks to 1 month. And if the patient lands up with volume overload and has encephalopathy, has hyperkalemia, acidosis, and has renal dysfunction, then these patients may require dialysis. And the modality of dialysis would be hemodialysis for older children. And especially if they have come with fluid overload, then hemodialysis is a better modality because you can remove fluid fast in such situations. And even for hyperkalemia, hemodialysis is a better modality as compared to peritoneal dialysis, which is a slow process. Now, a word of caution regarding the use of ACE inhibitors in patients with acute glomerulonephritis. Well, you should not use them because all these patients are having some form of renal dysfunction, and they have reduced GFRs. So if you use ACE inhibitors on a background of reduced GFR, you are bound to cause more severe hyperkalemia, and you are bound to worsen their renal function. So what is the course of acute glomerulonephritis? Well, it resolves spontaneously in within 1 to 2 weeks in almost 95% of the patients. So that is the reason why they need only a symptomatic management, and hypertension and gross hematuria resolves over a period of 2 to 4 weeks. However, microscopic hematuria can persist up to 1 year. So you don't need to do anything for this. Just reassure the family and keep calling them after every 3 months, looking at their blood pressures and looking at their urinalysis reports and looking at their KFTs. And you just need to follow them up for 1 year. After that, most of the hematuria will also disappear. And the complement levels usually return to normal within 6 to 8 weeks. But if they persist beyond 12 weeks, then these patients may require biopsy. And end stage kidney disease, or ESRD, which was as it was called earlier, occurs in less than 2% of these patients, and most of these patients will develop antibodies to streptococcal antigen. Therefore, the recurrence is highly unlikely. So it's usually a one-time disease in pediatric population. So I think that's the last slide. So just to recapitulate, nephrotic syndrome in children is primarily a minimal change disease which occurs in almost 90% of the pediatric nephrotic syndrome, and less than 10% will be contributed by steroid resistant nephrotic syndrome, which primarily occurs due to focal segmental glomerulonephrosis or MCD, and drugs like cyclosporine and tacrolimus are reserved primarily for patients with steroid resistant disease, and most patients with childhood nephrotic syndrome will self-resolve of the condition once they achieve puberty, because with the achievement of puberty, the T cells we know decline significantly because of thymic aplasia and loss of the lymphoid tissue as well. And so because of that, certain significant changes happen during puberty when most of these children will go into permanent remission. So most of these children will require during their childhood lot of support from pediatric nephrology services in the form of treatment of relapses and treatment and relevant immunization, and taking care of the complications of therapy which may be related to the disease or related to the treatment. And acute glomerulonephritis occurs much less frequently as compared to nephrotic syndrome, yet it should be managed mostly conservatively by taking care of by using supportive therapy alone. But a small proportion of nephrotic syndrome, less than 5%, may present with rapidly progressive renal failure, may require an early renal biopsy, and may require intense immunosuppression if they have a crescentic glomerulonephritis type of picture. So I think that's the last slide, and thank you for patient hearing. And if you have any questions, I will answer here. Are there any questions? You could just message if yes or no at least, because this is only a one-way thing. I'm not able to even gather whether you guys are there or not. Okay. Now, regarding the overfill and underfill, as I said, overfill is a situation which you see in patients of steroid-resistant nephrotic syndrome. As I said, most of these patients will have some biopsy changes. They will have tubular interstitial damage also. So once you have glomerular damage, you expect a fall in GFR. So if there is a primary fall in GFR, less amount of filtration will happen, and because of that, there will be a tendency of the body to have be in fluid overload, because reduced GFR will cause hypertension, and it will also cause predisposed to fluid overload as it happens in patients of AKI. So these are the patients which will be essentially, they will have hypervolemia. So if you use diuretics in these patients, it will be very useful. But if you use albumin in these patients, it will worsen their fluid overload. That is why, the choice whenever you encounter a situation of hypovolemia, that is a shock or hypovolemia, is a choice between crystalloid or colloid. So child of nephrotic syndrome, if he comes in shock, you will give him a colloid. In absence of colloid, you can give crystalloid also. So overfull is essentially because of reduced GFR, whereas underfill is happening in a situation of normal GFR, but because of persistent gross proteinuria, and that proteinuria is causing hypoalbuminemia, which is causing a reduced oncotic pressure and hypovolemia. So that is the reason why albumin works well in this situation, whereas diuretics work well in the other situation where you have fluid overload. If you have any more questions, if not, then when we meet in person, then when we discuss cases of nephrotic syndrome, we can discuss other issues and practical issues in greater details. Okay. Thank you so much, guys. Thank you. So I'll stop here because I have to go to my clinical posting as well. So thank you. And I'm ending the lecture here. Okay. Thank you.